Checkpoint 1. Trauma and transplants. This covers MCQs 1 through 5. Let's go.
Starting right off with question 1. You've got a patient heading in for a kidney-pancreas transplant. Between HbA1c and C-peptide, what's the most sensitive test here? The answer is absolutely C-peptide. Why? Because it specifically measures endogenous insulin secretion. This is the exact test you need to accurately assess the patient's residual beta cell function before you move forward with that pancreas transplant.
Moving to question 2, which deals with a surgical injury to the ureter. Now, if it's a clean transection, the correct answer is a tension-free, end-to-end ureterostomy over a JJ stent. But watch out for this trap. Notice how a tiny change in the scenario flips the answer entirely. If that transection happens specifically in the lower third, say during a hysterectomy, you don't do an end-to-end repair. Instead, the correct answer becomes a ureteronoocystostomy.
Okay, question 3. A patient comes in with a knee joint dislocation and no distal pulse. Even after you reduce it, still no pulse. The answer? Popliteal artery injury. It's a simple rule of thumb. Persistent absence of a pulse literally screams vascular injury until proven otherwise. But hey, what if the pulse does return after reduction? Your immediate next step shifts. In that case, the correct answer is to grab a Doppler or CTA to double-check that vascular integrity.
Let's knock out questions 4 and 5. What are the indications for a CT scan in a head trauma patient? Well, amnesia lasting more than 30 minutes, a GCS dropping below 13 at any time, or the presence of seizures. So the answer here is all of the above. And for question 5, if you're looking for the absolute best investigation for a complex or multiple fistula in ano, the answer is an MRI. It is hands down your gold standard for those tricky, recurrent cases.
Moving right along to checkpoint 2, acid, base, and diagnostics. This covers MCQs 6 through 10.
All right, question 6. We have an acid-base balance scenario where the patient suddenly doubles their rate of respiration. The correct answer? Metabolic acidosis. The key here is recognizing that a doubled breathing rate is a classic rapid compensatory mechanism. The body is desperately trying to blow off CO2 to fix that underlying metabolic acidosis.
Let's compare questions 7 and 8 side by side. It's super helpful. In question 7, a pH of 7.2, a low PCO2 of 20, and a low bicarb of 14 points you straight to metabolic acidosis. Simple enough. But look at question 8. Throw in Kussmaul breathing in a diabetic patient, drop that pH down to a severe 7.15 and a bicarb of 10. That context shifts your specific diagnostic answer to a high anion gap metabolic acidosis. For question 9, we've got a pure rapid-fire anatomy recall. If a patient presents with damage at the teres tuberosity, you've got to identify the affected nerve on the spot. The correct answer points straight to the axillary nerve. Just lock that anatomical association right into your memory.
Here's question 10. A patient with a history of a cholecystectomy now presents with symptoms of acute pancreatitis. To confirm this diagnosis, ask yourself, which enzyme do you absolutely need? The correct answer is serum lipase. It's the highly specific diagnostic enzyme you have to look for in these acute pancreatitis scenarios.
Halfway there, checkpoint 3, trauma and biliary issues, hitting MCQs 11 through 15.
Question 11 highlights a really vital diagnostic sequence. Imagine a patient with right upper quadrant pain, jaundice, and raised bilirubin, but their ultrasound is totally normal, no stones seen. The correct management answer is to get an MRCP. But wait, once that MRCP confirms a common bile duct stone is the culprit, you have to immediately step up your game. The correct answer then becomes an ERCP with a sphincterotomy.
Let's lock in some classic triads for questions 12, 13, and 15. A ventilator patient with zero eye or motor response, they get a GCS score of V1, T for intubated unresponsiveness. For question 13, if you see chest trauma with absent breath sounds and hyperresonance, that is the textbook answer for a tension pneumothorax. And question 15, a spinal injury presenting with neurogenic shock is definitively marked by the answer bradycardia paired with hypotension.
Jumping back to question 14, which emphasizes the surgical approach for salivary stones. The treatment for a mandible duct stone is simply stone retrieval and repair. More specifically, though, if that stone is sitting in the distal Wharton's duct, it's best managed with a direct transoral stone removal. Nice and straightforward.
All right, checkpoint 4, neuro, skin, and GI. We are on to MCQs 16 through 20.
Safety is the absolute priority here in question 16. What do you do if an inguinal hernia is reduced after general anesthesia? The correct answer dictates you must perform a laparoscopy to explicitly ensure the gut is viable. You just can't proceed blindly. Meanwhile, for question 17, altered level of consciousness is the correct answer for the very first initial warning sign of raised intracranial pressure.
Now, question 18 is a classic dermatology trap. You're presented with an actinic keratosis lesion that's bleeding, scaling, and growing, but with no lymph node involvement. You have to remember this specific progression path. The correct answer for what this most commonly progresses into, squamous cell carcinoma. Keep an eye out for that one.
Okay, question 19. If a patient on total parenteral nutrition suddenly develops new onset pain and weakness, the answer strongly points to hypocalcemia. Moving right into question 20, dealing with esophageal carcinoma presenting with progressive dysphagia, the correct answer for your absolute best initial investigation is an upper GI endoscopy with biopsy. Never ever delay direct visualization and tissue sampling when you see progressive dysphagia.
And we've made it to the final stretch. Checkpoint 5, Ethics and Infections, MCQs 21 through 25.
Let's knock these out. For question 21, a patient is 5 months post-op and can't work because their ankle movement is severely stiff. The answer? Cast disease. In question 22, the most common basal cell carcinoma found on the nasolabial fold is the nodular subtype. And for question 23, if an HIV patient needs surgery, objectively proceed. The answer is to simply perform the surgery using standard protective measures.
The big takeaway for question 24 deals with medical ethics and logistics. You have a brain-dead patient, and their attendant has agreed to organ donation. But even with that consent, you don't just proceed on your own. The correct answer is that you must formally discuss the case with the organ transplant team before taking any further action. Protocol is key here.
Finally, question 25 covers needle stick protocols. If a healthcare worker gets pricked by a hepatitis B positive patient, immediately look at their status. If they're fully vaccinated with a protective titer, the correct answer is no treatment. But if they are an unvaccinated worker, the correct management is to immediately give HBIG along with the hepatitis B vaccine.
Starting right off with Q26, a patient is suspected of having Freiberg disease. What's the first-line investigation? Well, it's a plain X-ray. It's always your starting point, right? You only move on to an MRI for early disease detection if those initial X-rays come back completely normal. Moving to Q27, a patient presents with upper GI obstruction and persistent vomiting. What metabolic state are you expecting here? The answer is hypokalemia with aciduria. We all know persistent vomiting famously causes hypochloremic, hypokalemic metabolic alkalosis, but you've got to remember that tricky paradoxical aciduria that tags along with it. Now, Q28 tests a super common presentation. A 90-year-old patient suffers a Coles fracture. What's a recognized complication? You really need to watch out for acute median nerve entrapment. I know you might be tempted to guess non-union since the patient is elderly, but honestly, non-union in a Coles fracture is actually pretty uncommon.
Let's look at Q29. The original recall fragment gave us a suprapubic scenario that was a bit inconclusive. So since that piece is incomplete, let's pivot seamlessly to the highly tested IMM counterpart. A patient has a suspected bladder injury after pelvic trauma, and the initial retrograde cystography is inconclusive. What's your very next step? Don't rush them to the OR. The correct move is urethral catheterization and a repeat cystography. You absolutely must definitively image that bladder to pinpoint the exact site of the leak before you make any surgical decisions. Okay, number 7. For Q30, the recall missed the exact lidocaine concentration for a 55 kilogram patient, but it targets a crucial absolute maximum. And that number is 7 milligrams per kilogram. That is the max recommended dose of lidocaine when it's combined with adrenaline. Lock that number in your brain. The adrenaline causes local vasoconstriction, which delays systemic absorption and safely lets you hit that higher maximum dose.
Let's keep the pace brisk with this next set. Q31. What's the mechanism of action for local anesthetics? Simple. It's the blockade of voltage-gated sodium channels. Next up, Q32 gives us the anesthesia grading scenario. You've got a patient with high blood pressure, an ejection fraction of 35%, and they have difficulty stair climbing. What's their ASA classification? It's ASA 3. An ejection fraction sitting around 35% paired with a substantive functional limitation like that perfectly defines severe systemic disease. Boom, ASA 3. And for Q33, after surgical drainage of a carbuncle, how do you close the wound? Secondary closure. Carbuncles are highly infected spaces, right? If you stitch them closed, you're literally just trapping the infection inside. They have to be left open to heal by secondary intention.
Let's group these next 3 surgical topics together. Q34. During a TURP,
a transurethral resection of the prostate. The patient suddenly experiences severe leg twitching. Which nerve just got stimulated? That would be the obturator nerve. The electrical current stimulates it, and it causes a very distinct adductor muscle jerk. For Q35, they're asking for the most potent oral opiate on a milligram-to-milligram basis when compared to oral morphine. Out of the standard options you'll see, oxycodone is the answer. It's significantly more potent. And Q36, a patient has continuous urinary leakage, literally soaking her clothes after a prior total hysterectomy. Diagnosis? That continuous leakage following pelvic surgery classically points straight to a vesicovaginal fistula.
And this brilliantly illustrates our next concept for Q37. The recall gave us a dashboard trauma that resulted in a posterior hip dislocation and asked for the nerve features. Picture this. When a knee slams into a dashboard, it drives the femur backward, right? That causes the posterior hip dislocation. And the structure sitting directly in the crosshairs of that displaced femoral head is the sciatic nerve. So a posterior hip dislocation most commonly injures the sciatic nerve.
Moving right along to Q38. You find a 3-centimeter simple cyst in the kidney. What's the management? Please don't overthink this one. For a simple, asymptomatic renal cyst, conservative observation is the only correct answer. Because simple cysts have absolutely zero malignant potential, you just watch them.
Let's slow down the pace just a tiny bit for Q39. The original recall text actually mixed up Hinchy grade 3 with a pelvic abscess, which is a stage error in the source material. So let's look at the correct clinical scenario here. What's the preferred management for a hemodynamically stable patient with Hinchy 2 diverticulitis, meaning they have a localized pelvic abscess? Well, because they are stable, you want to avoid immediate major surgery. The standard of care is percutaneous drainage coupled with intravenous antibiotics.
Now, what's really interesting here is how it perfectly contrasts two wildly different stone management scenarios. In Q40, you've got a tiny 5mm stone and a pregnant patient. A small stone plus pregnancy completely dictates conservative management. But consider the scenario in Q41. You have a massive 3-centimeter stone sitting squarely in the renal pelvis. Conservative care is definitely not going to cut it, and neither will shockwave therapy. A large stone of this size in the pelvis absolutely demands a percutaneous nephlolithotomy, or PCNL.
For Q42, the original exam recall was actually missing its X-ray image of the Ilizarov frame. But hey, we can test your foundational knowledge regardless. What is the Ilizarov frame primarily used for? It's the classic example of circular external fixation, and it's heavily utilized in orthopedics for complex fractures and limb lengthening.
Q43 is a rapid-fire radiological buzzword. An X-ray shows a classic onion skin appearance on the periosteum. Diagnosis? That multi-layered periosteal reaction should trigger an immediate, undeniable mental reflex: Ewing sarcoma. No hesitation on that one.
Next up, Q44 presents a painful lesion right below the fingernail, a 3-centimeter suspected subungual melanoma. How do you initially confirm this? A simple punch or shave biopsy just won't give you the full picture. The definitive first step here is an excisional biopsy of the lesion and the underlying nail bed. You have to ensure you get the full depth for proper staging.
Q45 asks for the management of carpal tunnel syndrome. Before you even start considering steroid injections or a surgical release, quickly confirm that the initial, non-operative management is always the application of a wrist splint, especially for nighttime use. It keeps the wrist neutral and maximizes the space in the carpal tunnel. So the crucial point is right here on Q46. A patient is 4 weeks out from a nasty attack of acute pancreatitis and develops infected walled-off pancreatic necrosis. Preferred management. Listen, we no longer rush in for an immediate massive open laparotomy. Modern surgical doctrine dictates an image-guided drainage utilizing a minimally invasive step-up approach. Transitioning logically from necrosis to pseudocysts, Q47 asks, what's the initial investigation for a suspected pancreatic pseudocyst that's causing abdominal pain? The gold standard, initial imaging modality to truly map out the anatomy and rule out complications is a contrast-enhanced CT scan. It perfectly lets you evaluate the cyst wall maturity and see its exact relationship to surrounding vessels. We're nearing the finish line. Notice how Q48 and Q49 are testing the exact same diagnostic principle. Q48 asks for the first investigation for a thyroid mass. Q49 asks for the first investigation of choice for a midline neck mass. The answer to both? An ultrasound of the neck. Ultrasound is the undisputed, non-invasive first-line investigation for virtually all anterior neck masses, simply because it provides incredible detail of superficial structures without exposing the patient to any radiation. And finally, Q50 brings us back to some quick trauma math. A patient opens their eyes to pain, makes incomprehensible sounds, and withdraws from pain. What is their Glasgow Coma Scale?
Let's break down the math to get to 8. Eyes opening to pain, that's a 2. Making incomprehensible sounds, also a 2. Withdrawing from pain, that's a 4. Add them all up, E2, V2, M4, and you get a total GCS of 8. Question 51. Wow. You've got this classic triad, right? Altered facial appearance, enlarged extremities, and that super specific visual field defect, bitemporal hemianopia. Put those together and boom, it's unequivocally a growth hormone secreting pituitary adenoma. Remember, that visual defect pops up because the expanding adenoma is literally pressing right on the optic chiasm. Now, question 52 brings up a distinction you absolutely must have locked down for exam day. The setup mentions right upper quadrant pain, jaundice, and a liver abscess. You've got to separate the pathogens in your head based on the abscess type. Pyogenic liver abscess, think E. coli. But if they specifically call out an amoebic liver abscess, your brain needs to instantly pivot to Entamoeba histolytica. Don't let them trick you on that one. All right, let's rapid fire through 53, 54, and 55. If your post-splenectomy patient has a yellow fluid leak, the injured organ is the pancreas, for sure. Why? Because a pancreatic tail injury is a notorious complication there. For 54, a DPL, or diagnostic peritoneal lavage, hits that positive threshold at over 100,000 red blood cells per cubic millimeter. And for 55, say you find a 1.5 centimeter neuroendocrine tumor right at the tip of the appendix and the CT is normal, your definitive fix is just an appendectomy alone. No need for a right hemicolectomy for something that size. Moving right along into our next block, questions 56 through 60. So, for question 56, the recall we're working from is actually a bit incomplete. It describes a post-appendicectomy patient showing up 17 days later with a mass and discharge, even on antibiotics. Honestly, without the rest of the stem, we can't nail down the exact diagnosis. On test day, you'll need to hunt for those differentiating keywords to figure out if you're dealing with a wound abscess, a stitch granuloma, or an enterocutaneous fistula. Just keep those 3 differentials on your radar. Question 57 is a pure association game. You need to firmly link the clinical condition pseudomyxoma peritonei directly to its primary source, which is a mucinous tumor of the appendix. See that condition, pick that tumor, simple as that. Now, question 58 perfectly contrasts 2 statistical study designs you are definitely going to be tested on. Studying a rare disease, your go-to is a case control study. On the flip side, if they ask you how to best calculate prevalence, you're looking for a cross-sectional study. Lock that in. For question 59, we're diving into some applied pharmacology. Imagine your post-op patient develops an immediate allergy to coamoxiclav, but they are fighting off a serious gram-positive infection. Looking at the choices, gentamicin, ceftriaxone, vancomycin, and metronidazole, your definitive, no-doubt answer is vancomycin. It's an absolute powerhouse for gram-positive coverage when penicillins are totally off the table. And look at question 60. It brings back a super familiar pattern from just a few minutes ago. We've got altered facial features and bitemporal hemianopia again. But this time they throw on that classic phrase, shoe not fitting. Well, shoes suddenly not fitting means enlarged extremities, which screams acromegaly. So once again, the underlying culprit is a growth hormone secreting pituitary adenoma.
Halfway through, let's seamlessly transition into questions 61 through 65.
Okay, tackling 61, 62, and 63 together here, you can literally just correlate the patient demographic directly to the pituitary pathology. Young female with 6 months of amenorrhea and galactorrhea, that points straight to a prolactinoma. An adult with a non-functioning adenoma, well, since it's not secreting active hormones, it's going to present via mass effect. So think headaches and bitemporal hemianopia. And finally, if a child presents with a defect in this region, your number 1 suspect is a craniopharyngioma. Shifting gears to trauma protocols for question 64. The STEM gives us a trauma patient with a Glasgow Coma Scale, a GCS of 7. The golden rule here? Any patient with a GCS of 8 or less needs definitive airway protection. So intubation is absolutely your mandatory first step. Do not even think about a CT scan or secondary evaluation until that airway is secure. Question 65 is a lightning-fast visual recall. If your exam stem describes a crescent-shaped hyperdense lesion on a head CT, that is definitively a subdural hematoma. The blood literally tracks along the contour of the skull to create that classic crescent look. All right, pushing into our next block, let's tackle questions 66 through 70. For 66, if you see a sudden thunderclap headache, your brain should immediately jump to a ruptured berry aneurysm. Then in 67, it's all about neurology localization. A patient who suddenly can't dress one side of their body and can't feel that side, that specific deficit localizes strictly to the parietal lobe.
Now, question 68 is actually kind of funny because it highlights a quirk in exam recalls. The original text literally said Camembert cheese Bactroids, which, let's be real, is definitely a transcription error. In the medical exam world, eating unpasteurized Camembert cheese is a classic established risk factor for Listeria monocytogenes, not Bactroids. So if soft cheese pops up on your exam, lock in Listeria. Grouping 69 and 70, we are hitting both the surgical and microbiological sides of gas gangrene. For 69, the non-negotiable surgical management for gas gangrene is an aggressive, wide excision of all that necrotic tissue. And for 70, the most common organism driving this infection is Clostridium welchii, which you'll also see widely referred to as Clostridium perfringens. You're doing amazing hanging in there. Let's push through this final block of the explainer, questions 71 to 75. Let's finish strong. For 71, an impacted mandibular third molar drains primarily to the submandibular node. Simple anatomy. For 72, if you've got a patient with paraphimosis and manual reduction just isn't working, the required next step is a dorsal slit. And for 73, think about a patient with liver cirrhosis who's actively bleeding. They aren't making coagulation factors, right? So you need to replace them directly by administering fresh frozen plasma, or FFP. Question 74 tests a very strict clinical definition. Massive transfusion isn't just a subjective, thrown-around blood kind of term. It definitively means the transfusion of 10 units of packed red blood cells within a 24-hour period. You need to lock that exact number and time frame into your memory. And here we are at our final recall, question 75. This is all about the proper sequence in trauma. You have a patient with a hand laceration. Before you grab sutures, before you even think about tendon repair, and before you order an x-ray, your absolute mandatory first step is a thorough neurovascular exam. You have got to establish that baseline function before you do anything else.
We're looking at the initial injury response. What actually happens the very second a vessel is injured? Well, the immediate step 1 response is vasoconstriction. This happens way before any platelet plug even starts to form. But what's really crucial here, the core IMM point you need to remember is that following that initial vasoconstriction, the absolute next step in primary hemostasis is platelet aggregation. Lock that chronological sequence into your brain. Vasoconstriction, then platelet aggregation.
Moving right along to question 77. The recall stem here gives us a patient with abdominal pain and a very specific, almost free giveaway radiological clue, the coiled spring appearance. When you hear those exact words for an abdominal contrast study, your brain should immediately scream intussusception. It's this highly characteristic sign where the bowel basically telescopes into itself, and it literally looks just like a coiled spring on the scan. It's pure, simple pattern recognition.
All right, question 78. This one presents a classic GI bleed scenario. We've got a patient presenting with painless, fresh PR bleeding, that's bleeding per rectum, and her hemoglobin is dropped down to 8.8. Now, if we think about the related IMM options, sure, things like ulcerative colitis, rectal carcinoma, and diverticulitis are totally on the differential. But the single most common cause of painless, fresh PR bleeding in an adult, it's hemorrhoids. That is your most likely and absolutely correct answer.
For question 79, we've got a 50-year-old patient who's both diabetic and an alcoholic coming in with gait issues because of a femoral problem. The stem is asking for the root cause of avascular necrosis of the neck of the femur. So from the standard risk factors they give you, diabetes, osteoarthritis, gout, the distinctly recognized classic risk factor for avascular necrosis, or AVN, of the femoral head is actually alcohol. Now, question 80 shifts gears into trauma. Picture this, you've got a patient with a neck injury and they're presenting with surgical emphysema. The question asks for your very first initial priority. Listen, the absolutely crucial takeaway here is that airway protection always comes first. The correct answer is to secure the airway. Do not get distracted by the surgical emphysema. You have got to secure that airway immediately.
Let's hit question 81 and see how this builds out your trauma management protocols. A patient presents with a contaminated household injury, and here's the real kicker, they have absolutely zero previous tetanus immunization history. Nothing. So, what's the appropriate management? Well, because they are unimmunized and the wound is dirty, you need the full triad. The correct answer is tetanus immunoglobulin plus the tetanus vaccine plus proper wound care. You literally need all three to cover them safely.
Question 82 is just a fantastic high-yield one-liner. When you're asked for the primary cause of delayed wound healing in a general clinical recall scenario, you need to look for mechanical obstructions to healing. The correct answer here? A, foreign body. Simply put, if a wound just isn't closing, check for what might have been left inside. Finishing off Block 1 with question 83, we have a complex patient on warfarin. Their INR is elevated, and they suddenly require an urgent ERCP, an endoscopic bile duct procedure. We need to correct that coagulopathy fast. Now, while vitamin K is an option, it takes way too much time. The brilliantly simple, fastest correct answer to reverse warfarin for an urgent procedure is fresh frozen plasma, or FFP. It replaces those clotting factors immediately. Bam! Problem solved.
All right, keeping the momentum going, let's dive into Block 2, nerves, infections, and one-liners. We're running through questions 84 to 93.
Questions 84 and 85 give us a really interesting side-by-side clinical comparison. For question 84, if the radial side of the finger is affected and the patient physically cannot pick up objects, that points directly to a median nerve injury. Now contrast that with question 85, a forearm laceration where sensation is lost on the medial side of the finger. That medial sensory loss, that tells you it's an ulnar nerve injury. So, radial side motor and sensory limits point to median. Medial side sensory loss points to ulnar.
For question 86, we're dealing with a pulp space infection in the finger. Because of the unique closed compartmental anatomy of the digital pulp, pressure builds up incredibly fast. The severe complication risk you absolutely must watch out for, which is the correct answer here, is osteomyelitis, an infection of the underlying bone.
Let's look at another powerful comparison, this time for knee swellings in questions 87 and 88. For 87, if you've got a swollen knee due to septic arthritis, the management is all about mechanical clearing of that infection. The answer is arthroscopic lavage. But for 88, if you have an acute hemarthrosis, meaning bleeding right into the knee joint, in a patient with hemophilia, you don't mechanically clear it first. No, you have to fix the underlying systemic deficit. The first-line treatment there is factor replacement. 2 swollen knees, completely different pathophysiology, and completely different answers.
Okay, questions 89, 90, and 91 are rapid-fire one-liners. Let's hit them sequentially. Question 89. Post-op restlessness? Always think electrolyte imbalance first. The answer is hyponatremia. Question 90. A suture tied too tight? That causes tissue ischemia, which ultimately leads to, the answer, infection. And question 91. What is the standard safe blood storage temperature? The answer is firmly between 2 to 6 degrees Celsius.
Closing out Block 2 with our endocrine questions 92 and 93, let's connect the pathology directly to the imaging. Question 92 notes that the classic bone disease osteitis fibrosis cystica is a massive indicator of long-standing primary hyperparathyroidism. Now jump right to question 93. If you diagnose that primary hyperparathyroidism and you need to operate, what's the best preoperative localization investigation? The answer is a radioactive system EB scan. That scan perfectly localizes the overactive gland before you even make a single incision.
We are on the home stretch. Block 3. Pre-op, post-op, and wrist swellings. Wrapping things up with questions 94 to 100. Let's finish strong.
Question 94 asks for a very specific numeric threshold. What is the safely required range of platelets for a patient undergoing general surgery? That critical magic number is 50,000. You absolutely need a platelet count of greater than or equal to 50,000 per microliter to safely proceed with surgery.
Question 95 is a classic ward scenario. A patient develops a fever on the second post-operative day. Now, while UTIs or wound infections definitely happen later on, the most likely cause of a fever, specifically on day 2, which is usually due to atelectasis or pneumonia, is a pulmonary problem. Day 2 fever? Think lungs.
Moving over to pediatrics with question 96. A 9-month-old baby is scheduled for surgery. Which pre-op test is absolutely required? Thinking about our usual protocols, well, we don't routinely do chest x-rays or coagulation profiles on otherwise healthy infants. The essential, correct preoperative test required here is just a complete blood count, or CBC.
For question 97, we're looking at airway assessment. The recall stem describes an airway where only the soft palate and the base of the uvula are visible. This exactly defines a Mallampati-3 score. It indicates a severe or difficult airway, letting the anesthesiologist know they need to be seriously prepared before induction.
Question 98 dives into a bit of pain management history. What technique has been widely regarded as the absolute gold standard for post-operative analgesia in major abdominal and thoracic surgery since roughly 1979?
While things like oral paracetamol and NSAIDs are fantastic adjuncts, the definitive gold standard answer is epidural analgesia. It just provides vastly superior, localized pain control for those massive procedures.
And we conclude today's explainer with a fascinating overlap in questions 99 and 100. Question 99 describes a swelling on the back of the wrist that causes pain during repetitive motion, like typing. Question 100 describes the most common soft tissue swelling on the dorsum of the wrist, attached to bone, with pain during clutching. Do you see it? Both of these diverse clinical presentations confidently point to the exact same diagnosis, a ganglion cyst. It's genuinely amazing how recognizing the underlying pathology makes the exact wording of a question secondary.
Starting off with Q101. A patient with a tibia-fibular cast comes in with primary pain. Now, the clinical alarm bells here should be ringing loud and clear for suspected compartment syndrome. The verdict? You gotta remove it immediately. Splitting or taking off that cast is step 1. Shifting gears to outpatient care in Q102, an infertile couple walks in. What's the absolute first, least invasive test? It's always a semen analysis. Always. Finally, for Q103, hitting the exact timing for prophylactic antibiotics is absolutely crucial. To get maximum efficacy, you have to administer them strictly within 60 minutes or 1 hour before the skin incision.
Keeping this sprint going, Q104 puts you right in the OR. You encounter a blind end vessel and, the anatomy is unclear. The safest action? Stop and identify the structure before proceeding. Never, ever divide something if you don't know what it is. In Q105, dealing with a retractile testis doesn't mean rushing straight to surgery, you know? The verdict here is observation with periodic follow-up since spontaneous resolution is pretty common. But Q106, that brings massive diagnostic urgency. A 7-year-old boy wakes up with sudden testicular pain and a mild fever. Listen, in this age group, acute nighttime pain is testicular torsion until proven otherwise. Literally, no time to wait.
Awesome work so far. We're keeping the momentum incredibly high as we transition directly into Block 2, renal to sterilization. That's MCQs 107 to 112.
All right, tackling pelvo-ureteric junction obstruction, or PJO in Q107. The functional investigation of choice here is the MAG-3 renal scan. Taking it a step further in Q108, what if a patient has recurrent PJO but they've already had a previous pyeloplasty? The standard, minimally invasive verdict in those selected patients is an endopyelotomy.
Now, Q109 presents this really stark, high-yield contrast. Think about an electrical injury. What actually causes the primary tissue damage? Is it the electrical effect or the thermal effect? Well, the verdict is the electrical effect. This is such a brilliant illustration of a core trauma concept. The most severe damage isn't the thermal burn you see on the surface. It's like an iceberg. It's the invisible, deep tissue destruction caused by the internal current passing right through the body's internal pathways. Definitely keep that distinction locked in.
Powering right along, Q110 classifies a burn that has both superficial blistering and areas of full-thickness injury simply as a mixed-depth burn. Pretty straightforward. For Q111, a patient comes in with dyspepsia, weight loss, and dysphagia that's actually worse with solids than liquids. This points directly to a definitive verdict, endoscopy plus biopsy. You absolutely have to directly visualize and sample that tissue to rule out a malignancy. Finally, Q112 shifts us over to hospital protocols. How do you confirm an instrument has actually been processed for sterilization? Autoclave tape. It physically changes color to confirm exposure to the process.
And that brings us right to the halfway mark. You are doing great. Let's propel ourselves right into Block 3, Protocols and Pathology, which covers MCQs 113 through 118.
Okay, let's rapid-fire some strict sterilization parameters, because honestly, these are purely high-yield memorization checkpoints. In Q113, standard steam autoclaving time and temperature is strictly 121 degrees Celsius for 15 minutes. Meanwhile, Q114 asks about flexible endoscopes. You obviously can't use steam or dry heat on those delicate scopes, right? So the chemical agent of choice is glutaldehyde.
Let's look at some quick anatomical and pathological clues here. For Q115, a female patient has a swelling below the inguinal ligament with a positive cough sign. The word below is your absolute dead giveaway here. The diagnosis? A femoral hernia. Moving to Q116, what type of basal cell carcinoma, or BCC, do you typically see on the nasolabial fold? That's classically the nodular subtype. It's actually the most common subtype you're going to find in that specific head and neck region.
Wrapping up this third block, Q117 asks, what signifies a poor prognosis for a cutaneous squamous cell carcinoma on the cheek? Out of all the clinical and histological signs, poor differentiation strongly predicts a worse, much more aggressive outcome. And for Q118, this is a truly vital protocol for your surgical rotations. How do you handle a pre-operative patient who's currently taking warfarin? The standard bridging therapy rule here is you stop the warfarin 5 days prior to surgery and you bridge them with low molecular weight heparin. You've got to minimize that bleeding risk while still maintaining anticoagulation.
You have made it to the final sprint. This is Block 4, the final stretch. We're tackling our last 5 questions, MCQs 119 to 123. Let's finish strong.
The absolutely crucial mathematical takeaway for Q119 is 36%. Let's talk about why. When you're calculating total body surface area for burns using the rule of nines in an adult, you just break it down like a puzzle. One entire lower limb is 18%, and the entire anterior trunk is also 18%. Add those together and you get exactly 36%. Simple, highly testable, and you can't forget it.
Moving to Q120, a trauma patient comes in with hypovolemic shock. So what is your absolute first assessment? Now, do not get distracted by the word shock here. The answer is airway assessment. The ATLS protocol strictly follows the ABCDE approach. Airway always comes first. Then, in Q21, finding a gallbladder polyp that is 2 centimeters or larger that mandates a laparoscopic cholecystectomy. Why? Because polyps that size carry a significantly high risk of malignancy.
To finish our strict sequence, we have 2 major pelvic trauma scenarios. In Q22, you have a patient with a pelvic fracture, scrotal swelling, and blood at the urethral meatus. Because of that blood, you never ever pass a blind Foley catheter. You have to evaluate with a retrograde urethrogram first. Finally, Q123, you have an unstable pelvic fracture presenting with hypovolemic shock. The acute management answer is an external fixator. By applying it, you are mechanically reducing the internal pelvic volume, and that effectively helps to tampen out the bleeding and control that severe, life-threatening hemorrhage.
Question 1. Marfan syndrome is inherited as A. Autosomal recessive, B. Autosomal dominant, C. X-linked dominant, or D. X-linked recessive. The correct answer here? It's B. Autosomal dominant. The reason you got to remember this is because Marfan syndrome is specifically caused by mutations in the FBN1 gene, and that specific gene mutation consistently follows an autosomal dominant inheritance pattern. Boom! Let's keep that momentum going. On to question 2. If a patient with a hepatic hydatid cyst worsens after 1 month of albendazole, do we A. Continue it, B. Use PAIR, C. Perform a laparotomy with cyst excision, or D. Just observe? The correct answer is C. Laparotomy with cyst excision. So the crucial point to take away here is this. When you have symptomatic or complicated hydatid cysts that are clearly failing medical therapy, like albendazole, they require surgery.
Question 3. What is the Broder's classification based on? Is it A. Tumor size, B. Degree of differentiation, C. Nodal status, or D. Depth of invasion? The answer is B. Degree of differentiation. The underlying reason is that the Broder's grading system is specifically designed to classify squamous cell carcinoma, SCC, according to the actual percentage of differentiated cells within the tumor.
Moving right along to question 4. The most common site of a venous ulcer is A. Lateral malleolus, B. Medial malleolus, C. Heel, or D. Dorsum of the foot. The correct choice here is definitely B. The medial malleolus. This is a classic presentation, you guys, because venous ulcers typically pop up right in that gator area, which is located right around the medial malleolus.
Okay, moving to question 5, we have a 5 centimeter laceration extending into the subQ tissue without muscle injury. However, the recall only indicates grade 03. Now, I want to briefly pivot here to explain the realities of exam recalls, because the exact grading system in this specific source is honestly a bit unclear. We can't safely reconstruct the original stem or the options. To keep our review strictly accurate and purely based on the facts provided, we just have to acknowledge this limitation and move forward without guessing.
And this brilliantly illustrates question 6, which asks, which ulcer classically has sloping edges? A. Arterial, B. Venous, C. Malignant, or D. Tuberculous? Well, the answer is B. Venous ulcer. Remember how we just discussed them hanging out by the medial malleolus? Physically, venous ulcers distinctly present with these shallow, sloping edges that contain granulation tissue. Linking those visual cues is key to locking it in your memory.
Question 7 gives us a patient experiencing painless bleeding at the end of defecation, accompanied by anal itching, all due to internal hemorrhoids. What's the best outpatient treatment? Your options are A. Hemorrhoidectomy, B. Rubber band ligation, C. Fissurectomy, or D. Lateral sphincterotomy. For this specific outpatient scenario, the answer is B. Rubber band ligation. It is absolutely the standard, optimal outpatient approach.
Let's rapidly hit question 8. Repeated wrist trauma causes avascular necrosis of which bone in Kienbach disease? A. Scaphoid, B. Lunate, C. Triquetrum, or D. Capitate. Go ahead and lock this one in. The answer is B. The lunate bone. It's uniquely susceptible to avascular necrosis from this specific type of trauma.
Question 9 shifts gears over to GI. Compared with the general population, Barrett's esophagus increases the risk of A. Squamous cell carcinoma, B. Adenocarcinoma, C. GIST, or D. Lymphoma. This points straight to B. Adenocarcinoma. You must firmly associate Barrett's esophagus with that elevated risk of esophageal adenocarcinoma. That's a crucial link.
All right, question 10. A patient has a chronic sternal wound after cardiac surgery. Which flap is commonly used for reconstruction? A. Tram flap, B. Omental flap based on the right gastroepiploic artery, C. Latissimus flap, or D. deltapectoral flap. For this specific post-cardiac scenario, the omental flap, that's answer B, provides the optimal coverage and vascular supply to really facilitate that healing.
Closing out part 1 with question 11. A strangulated femoral hernia requires A. Observation, B. Elective repair, C. Emergency surgery, or D. Truss. Now, I want you to mentally highlight the severity of the word strangulated in the stem. Because it's strangulated, the blood supply is compromised. And what does that mean? It means C. Emergency surgery is the immediate and literally the only correct answer here.
Let's move to and see how this builds. Surgery recalls part 2. We are powering through questions 12 to 22.
Starting part 2 with question 12. And right away we encounter our second incomplete recall. The original source fragment literally just says appendicitis with Addison. Reporting this totally impartially, this fragment is just insufficient to reconstruct safely. We aren't going to invent options, so we're pushing immediately forward to question 13 to keep our momentum high.
Question 13. A chronic non-healing ulcer on the lateral border of the tongue should be investigated by A. FNSC, B. Punch biopsy, C. Incisional biopsy, or D. Ultrasound. Now definitely note the classic location here on the lateral border. The correct choice is C. Incisional biopsy. And the reason? A persistent tongue ulcer like that is highly suspicious for squamous cell carcinoma, and that absolutely requires a definitive tissue diagnosis via an incisional biopsy.
Question 14 asks, sentinel lymph node biopsy is routinely indicated in which of the following? A. Basal cell carcinoma, B. Melanoma, C. Lipoma, or D. Actinic keratosis. Briskly moving on this one, the correct choice is B. Melanoma. Sentinel node biopsy is the standard procedure for staging its lymphatic spread.
Moving to question 15. The definitive treatment for a choledochocyst is A. ERCP, B. Cholecystectomy only, C. Complete cyst excision with Roux-en-Y hepatojejunostomy, or D. Observation. The definitive surgical answer here is unequivocally C. Complete cyst excision paired with a Roux-en-Y hepatojejunostomy. No shortcuts on that one.
Question 16 deals with the gallbladder. The definitive treatment for a symptomatic gallbladder mucocele is A. ERCP, B. Cholecystectomy, C. Antibiotics, or D. Aspiration. Pointing straight to the definitive management, the answer is B. Cholecystectomy. Simple rule: when it's symptomatic, the gallbladder needs to come out.
Question 17. The standard curative operation for a resectable periampullary carcinoma is A. Total gastrectomy, B. Right hemicolectomy, C. Pancreaticoduodenectomy, also known as the Whipple procedure, or D. Distal pancreatectomy. Really highlight the phrase resectable periampullary in your mind. This leads directly to confirming C, the Whipple procedure, as your standard curative operation.
Question 18 tests our anatomical pathology. The most common site of gastrointestinal tuberculosis is A. Duodenum, B. Jejunum, C. Ileocecal region, or D. Rectum.
Anatomically, we can identify answer C, the ileocecal region, as the classic and absolutely most frequent site for GITB.
Question 19. During surgery, a needle stick injury occurs. What should be done first? A. Ignore it. B. Continue surgery. C. Inform the lead surgeon. Or D. Leave the OR. Now, what's really interesting about this slide is how it pivots from medical theory to strict protocol. The immediate required action is C. Inform the lead surgeon. Safety and protocol always come first in the operating room. Question 20. A painless cystic swelling in the parotid of an elderly smoker is most likely A. Pleomorphic adenoma, B. Werthin tumor, C. Mucoepidermoid carcinoma, or D. Adenoid cystic carcinoma. The key clues here: elderly smoker and painless cystic parotid swelling. Those map perfectly to identify B. Werthin tumor as the most likely diagnosis.
Question 21 brings us to nerve injuries. In neuropraxia, A. Axon is divided. B. Endoneurium is disrupted. C. Conduction block occurs without axonal disruption. Or D. Complete nerve transection occurs. Reading through these gradings, we can easily confirm that C is the precise definition of neuropraxia. It's a temporary conduction block, but crucially, there is absolutely no disruption of the axon itself.
And finally, question 22. Zollinger-Ellison syndrome is caused by A. Insulinoma, B. Gastronoma, C. Vipoma, or D. Glucagonoma. We can confidently conclude this rapid-fire explainer by confirming answer B. Gastronoma. It's the defining cause of Zollinger-Ellison syndrome. And just like that, you have conquered all 22 sequential questions in this set. You dialed in on the statements, locked in the answers, and understood the reasons.
So for question 23, imagine a chronic smoker is planned for elective surgery. For maximum reduction in post-operative pulmonary complications, smoking should be stopped at least how long before the procedure? Well, the answer is 4 weeks. Why exactly? Because ceasing smoking for this very specific time frame significantly reduces both pulmonary and wound complications. Any shorter than that, and honestly, you just aren't getting that maximum physiological benefit.
Moving right along to question 24. What's the absolutely strongest risk factor for post-operative wound infection in a diabetic patient? The answer is poor glycemic control. Now, while hypertension and obesity are definitely factors, poor compliance that leads to uncontrolled diabetes is by far the strongest risk. Why? Because it literally impairs neutrophil function and directly messes with overall wound healing.
All right, let's look at this dramatic clinical scenario for question 25. A patient hears a distinct snap during intercourse, which is immediately followed by penile pain, swelling, and rapid detumescence. The correct initial management here? Immediate surgical exploration and repair. Now, you might be tempted by conservative measures like, say, ice packs, but current standard management demands urgent surgical repair. It consistently yields way better functional outcomes.
Let's rapidly map out 3 specific nerve injury questions side by side here. For question 26, a patient develops loss of sensation over the root of the penis and upper lateral scrotum right after an inguinal hernia repair. That injured nerve? The genitofemoral nerve. Next up, question 27. Which nerve lies posterior to the axillary artery before entering the spiral groove? That is definitively the radial nerve. And finally, question 28. Injury to the long thoracic nerve causes what classic sign? Winging of the scapula, for sure. Mapping anatomy directly to these clinical signs is exactly how you ace these exams.
Transitioning smoothly right into Block 2, Urology, Trauma, and Liver Transplants. We're moving straight into questions 29 through 34 here.
For question 29, we've got a 4 mm distal ureteric stone in a stable patient. The best initial management? Conservative management, specifically medical expulsive therapy. Look, with a stone that small, we just don't rush into surgical intervention. Immediately following that is question 30. What is the primary indication for a retrograde cystourethrogram? The answer is suspected urethral injury. You absolutely want to establish the integrity of the urethra before doing literally anything else. Okay, let's look at question 31. According to the AAST classification, a liver laceration involving more than 50% of a hepatic lobe surface area corresponds to which grade? Well, this extensive liver laceration corresponds precisely to a grade 3 injury. Memorizing these exact surface area thresholds is pretty much non-negotiable for trauma recall, so lock that one in.
Now, question 32 presents a patient who develops hypotension and bleeding during a massive transfusion. Which complication should be suspected? So the crucial point here is that when you're rapidly replacing blood volume with packed red blood cells, but without adequately replacing clotting factors and platelets, dilutional coagulopathy must be at the very top of your differential.
For question 33, consider a patient 6 weeks post-liver transplant who develops fever, abdominal pain, neutropenia, myalgia, and arthralgia. The most likely diagnosis here is a CMV infection, or cytomegalovirus. That specific timeline of 6 weeks, combined with neutropenia, is your major clinical clue pointing to CMV over things like acute rejection or bacterial cholangitis.
Question 34 brings us a 45-year-old man dealing with recurrent acute urinary retention paired with suprapubic pain. You've got to connect those two specific symptoms directly to a bladder stone. While BPH can definitely cause retention, that sharp, localized suprapubic pain heavily points toward a calculus obstructing the bladder neck.
We are making fantastic time here. Let's push right on into Block 3, burns, hernias, and disc prolapse, picking up with questions 35 through 39.
Hitting question 35. What's the immediate first aid for a scald burn? The definitive answer is running cool water for 20 minutes. You absolutely want to avoid putting ice directly on the burn. That just causes further tissue damage. And definitely stay away from home remedies like toothpaste or butter. To stick to cool, running water.
Question 36 is a very quick anatomical check. A Spigelian hernia occurs through the Spigelian fascia. It's a super intuitive answer, but honestly, it's one of those that easily trips you up if you overthink it and start reaching for the linea alba or the femoral canal on exam day. Trust your gut, it's the Spigelian fascia.
Let's pose question 37 regarding prophylactic timing. Because vancomycin prophylaxis requires a prolonged infusion time, mostly to avoid red man syndrome and to achieve proper tissue levels, when should it ideally begin? It must be started within 120 minutes before the incision. This is a very specific, highly tested exception to the standard 60-minute rule for most other preoperative antibiotics.
Let's see how this builds as we move to question 38. Pain radiating down to the lateral leg and the dorsum of the foot is most consistent with compression of the L4-L5 disc. And sequencing perfectly into question 39, neurofibromatosis type 1 is caused by mutation of what? The NF1 gene, located on chromosome 17.
All right, Block 4, vascular, biopsies, and skincare. We've officially reached the final stretch of our explainer. Let's keep that energy high as we tackle these last 5 questions, 40 to 44. Read question 40 with me. Lipodermatosclerosis is classically associated with which condition? Well, the answer is chronic venous insufficiency. This specific hardening and hyperpigmentation of the skin on the lower legs is really the hallmark consequence of long-term venous hypertension.
Maintaining our rapid rhythm here for questions 41 and 42. For question 41, the preferred biopsy for a suspected lymphoma is an excisional biopsy. Why? Because pathologists really need to see the completely intact nodal architecture to properly type the lymphoma, and FNAC just won't cut it. For question 42, when is CT myelography most useful? Basically, when an MRI is contraindicated, like in patients with certain pacemakers, or when an MRI is inconclusive.
Let's finish this sequential sprint strong. Question 43 asks what elastic pressure garments are primarily used to prevent. The answer is hypertrophic scars, particularly in burn patients. And this perfectly sets up a contrast with question 44. What is intralesional triamcinolone the treatment of choice for? Keloids. So remember, pressure for hypertrophic scars, steroid injections for keloids.
Question 45. Asymptomatic superficial cutaneous hemangioma is best treated with. What do you think? The answer is laser therapy. Selected superficial hemangiomas respond incredibly well to laser treatment. Lock that association in your brain right now.
Moving to question 46. If a child presents to you with palpable purpura over their legs, abdominal pain, and arthralgia, boom, that specific triad needs to set off alarm bells immediately. The diagnosis is Henoch-Scholin purpura, or IgA vasculitis. Stacking those 3 symptoms together instantly makes the diagnosis clear.
Question 47. The absolute hallmark feature of a cerebral concussion is a transient loss of neurological function. I really want to hit that word hard, transient. It's not permanent, it's transient. Hear it, internalize it, remember it.
Question 48. Let's imprint a direct clinical association right now. A successful sympathectomy equals a loss of sweating. It's clean, simple, and effective. Sympathectomy means loss of sweating.
Question 49. A fissure associated with Crohn's disease is typically what? Well, we need three very specific adjectives here. They are lateral, deep, and broad-based. Say them with me. Lateral, deep, broad-based. If you see those three words clustered together on test day, you are looking at a Crohn's fissure.
So, the crucial takeaway for question 50 is a really simple equation. What does a TrueCut biopsy actually provide? It gives you core tissue for histopathology. It isn't just fluid or cytology. Getting that solid core tissue is the whole point.
Question 51. Let's trace a clinical sequence. A woman has cyclical breast pain. Her ultrasound shows a 4-centimeter simple breast cyst, and fine needle aspiration cytology comes back entirely negative for malignancy. What is the very next step? Go ahead and do an aspiration.
Question 52 is a direct virology hit. Which test detects a current hepatitis B infection? The exact marker you're hunting for is HBsAg, the surface antigen. Really emphasize the word current in your mind. HBsAg means the infection is happening right now.
Trauma surgery for question 53. A gunshot injury causes 2 perforations of the bowel with contamination. Listen closely to that word, contamination. Because of that spillage, the right call isn't just a primary repair, it's a repair with a diverting stoma. The contamination absolutely dictates the stoma.
Question 54 brings us a classic pediatric case. An 8 to 12-year-old child comes in with hip pain and a limp. The most likely culprit, decisively, that's transient synovitis, which we also commonly call an irritable hip.
To wrap up this first block with question 55, which extraintestinal manifestation is classically associated with ulcerative colitis? Just hardwire this pairing in your brain right now. Ulcerative colitis goes hand in hand with erythema nodosum.
All right, fantastic work so far. Let's pivot to the second half, questions 56 through 66, and finish out our surgical recall sequence. Keep that focus sharp.
Keeping up our rapid-fire energy for question 56, a hernia through the linea alba without a true hernial sac. By definition, that is an epigastric hernia. Linea alba, no true sac, equals epigastric.
Question 57 tests a very common superlative. What is the most common cause of congenital hydrocephalus? Swift and confident on this one, aqueductal stenosis.
Question 58. Read the scenario carefully here. The initial treatment of an uncomplicated clavicle fracture is what? Focus cleanly on uncomplicated, because it leads us straight to the straightforward answer, an arm sling. There's no need to overcomplicate an uncomplicated fracture.
Now, what's genuinely interesting about this massive number, 100, is its clinical implication for question 59. A prostate larger than 100 grams that is causing bladder outlet obstruction requires a very specific approach. It is best treated with an open simple prostatectomy, meaning the enucleation of the adenoma. Over 100 grams, you go with an open simple prostatectomy.
Okay, hold up. Let's break our rhythm for just a second, because question 60 presents a vital exam trap. The original recall notes say 5 centimeter RCC stage 3, but pay very close attention to this staging discrepancy. By current TNM staging, a 5 centimeter tumor confined to the kidney is actually T1b, not T3. The original recall likely missed key information like renal vein or perinephric fat involvement. Seriously, do not fall into this trap on your exam.
All right, back to our rapid-fire pace for question 61. A patient has recurrent calcium renal stones and a high serum calcium of 12 milligrams per deciliter. The most likely underlying cause? Tie those high calcium markers directly to hyperparathyroidism.
Question 62 gives us a postoperative complication. Following a pancreatic necrosectomy, the drain is dumping 200 milliliters a day of high amylase fluid. You essentially have a pancreatic fistula on your hands. So, what's the mandatory next investigation? You need an ERCP.
Look at the acute presentation in question 63. A patient develops a sudden, painful, cold leg right after a myocardial infarction. This is acute limb ischemia. The definitive treatment for that post-MI embolus is an embolectomy.
Question 64 tests pure anatomical knowledge. Injury to the thoracodorsal nerve during a modified radical mastectomy weakens which specific muscle? Picture the surgical anatomy in your head. It's the latissimus dorsi. The thoracodorsal nerve supplies the latissimus dorsi.
Question 65. A persistent ulcer on the cheek that is highly suspicious for malignancy should be investigated by what method? Swiftly confirm it, you need a punch biopsy.
And finally, wrapping up our Set 3 recall sequence with question 66. A patient presents with intermittent abdominal swelling and pain, and imaging shows a cyst arising from the mesentery. The definitive treatment for this mesentery cyst is complete surgical excision. Wow, we've just blasted through 22 highly testable scenarios. Before we go, I want to leave you with a final thought. Notice how effortlessly your brain absorbs these complex medical correlations when we completely strip away the distractors and just present the raw structured facts. Try applying this hyper-focused, streamlined method to the rest of your studies. You'll be amazed at how much faster you retain things. Keep reviewing, stay focused, and go master that medical recall.